Hi, this is Nursing, and you are watching a discussion on diabetes mellitus. I want to talk to you about understanding hyperglycemia. Our blood sugar is regulated by the hormones insulin and glucagon, and these work as part of a negative feedback loop to promote homeostasis. When the blood glucose levels are elevated, the body releases insulin into the blood, which then attaches to the glucose and allows more glucose to enter the cells to be used as energy, and glucose that isn't used in the cells is then put into the liver or the muscle tissue or fat cells to be stored as glycogen for energy that could be used later on. If the person does not eat and the blood glucose levels fall, then the pancreas releases glucagon into the blood, and glucagon stimulates the liver to perform glycogenolysis, where that glycogen is then broken down into glucose and released into the bloodstream for use by the body as energy. So at any point in time, insulin and glucose are working kind of in harmony with each other to maintain a blood glucose level of 70 to 100. Hyperglycemia is the condition that occurs when the patient has a elevated blood glucose level. And we're going to talk about two different types of diabetes, type 1 and type 2. Type 1 occurs when the patient doesn't make any insulin at all, and type 2 occurs when the patient doesn't make enough insulin or when the cells become resistant to the insulin stimulus. Hyperglycemia increases the osmolality of the blood. It increases the viscosity of the blood. And as the body recognizes that the blood is becoming too thick, it triggers the body to drink more fluids to thin out the viscosity. So we have polydipsia, we have a lot of thirst. At the same time then, because water is a follower, it follows salt, it follows sugar, it follows protein, it follows any large molecule. Water then enters the bloodstream where the glucose is, following the glucose. And so you're drinking to kind of dilute the viscosity in the bloodstream, and now you have too much pressure in the bloodstream. So there's too much volume, and this triggers the kidneys to make more urine. So now I have polyuria. And if I have a glucose level greater than 220, I'll also have glycosuria, or I'll be spilling glucose into the urine. At the same time, my cells don't have enough glucose to do the work that they need to do. Even though there's lots of glucose filtering around in the bloodstream, there's nothing getting into the cells because of a lack of insulin or inadequate amounts of insulin. And so the body is sending signals to the brain saying, I'm hungry. And so the person has the classic 3 Ps of hyperglycemia: polydipsia, polyuria, and polyphagia. They drink a lot, urinate a lot, and eat a lot. Patients with type 1 diabetes may also develop ketone bodies and Kussmaul's respirations, which we'll talk about. With both types, type 1 and type 2, with the excessive urination, we get hemoconcentration, hypovolemia, dry cracked mucous membranes, hyperviscosity, hypoperfusion, and hypoxia. Diabetes type 1, when they're in DKA, they can get profound acidosis. Diabetes type 2 tends to only get mild acidosis. Hypo or hyperkalemia or normal serum potassium levels are all possible with hyperglycemia. So we need to keep a careful eye on their cardiac rhythm to make sure that they don't have something wonky going on with their potassium levels as well, especially if their sugar is out of whack. So let's start our discussion with diabetes type 1 or diabetes mellitus type 1, which is an insulin-dependent diabetic. This was oftentimes referred to as a juvenile onset diabetic, but we're kind of getting away from those terms. This is usually an autoimmune disorder. So either the person had a virus and then the body attacked the pancreas afterwards, or something happened and they lost their pancreas, like they had a trauma to the pancreas. In this case, the beta cells are not functioning in the pancreas, and so no insulin is made. And this really is the critical distinction between type 1 and type 2 diabetes. A patient who has type 2 diabetes can use insulin, but the patient who has type 1 diabetes is 100% dependent on insulin for life. The cells cannot utilize any glucose without insulin, and so the body then starts to burn fats and proteins for energy. They use the ketone bodies that are created by this process, the ketosis, to feed the brain. So the brain can actually use ketones as a form of energy. So it's kind of like a backup energy store. And this leads then to dramatic weight loss, dipsia, polyuria, polyphagia, the 3 Ps, and it can lead to diabetic ketoacidosis if untreated. The common signs and symptoms at onset, so never having had it before, are abdominal pain, thirst and dehydration, fatigue, flu-like signs and symptoms, polydipsia, polyuria, polyphagia. People with type 1 diabetes can eat and drink anything that they want as long as they cover it with insulin. And this is really critical because the education for a patient with type 1 diabetes is not, diet, exercise, lose weight, avoid carbs. It is learn how to calculate the carbs that you're eating and cover it appropriately with insulin. And if you're going to do activity, eat more before the activity because you're going to be burning more glucose during the activity. So really it's teaching them how to avoid hypoglycemia and hyperglycemia. Monitor closely for hypoglycemia, which would be considered quote unquote insulin shock, pale, cool, clammy skin, confused, tachycardic. Give oral glucose if the patient's awake, and IV glucose if they're unable to swallow or if they have altered mental status or unresponsive. So our key nursing interventions are focused really around teaching about diet and exercise, and insulin is going to be lifelong. We're going to provide basal insulin, which is typically once a day, something like Lantus. Sliding scale insulin with meals to cover the carbohydrates that they're eating, and or a pump. And an insulin pump is phenomenal. The new ones that they have actually can work in combination with an automatic blood glucose monitor that is constantly monitoring their blood glucose levels and adjusting the amount of insulin that they're receiving from their insulin pump. These are absolutely phenomenal, and it decreases the amount of highs and lows that they have. It decreases the amount of insulin that they need to get overall throughout the day, and it makes them much closer to almost having like an artificial pancreas. Like it makes it much closer to as if they didn't have diabetes. Teach them how to accurately monitor their glucose using the glucose monitor that they have. And some glucose monitors can be used on the arms rather than the fingers, but there are parameters that go along with those. So some can't be used for highs and lows on the arms. So if the person has the feeling that they're high or they're low, they really should be using capillary blood glucose from the fingers. Talk to them about follow-up. So the problems with long-term diabetes is about microvascular issues in the eyes, the kidneys, neurologic issues in the feet, and then monitoring the hemoglobin A1C to make sure that they have good control of their blood glucose. In addition to blood glucose monitoring, the skill of self-injecting insulin should be taught to every patient and their care provider or care partners. It's important that you rotate sites every week. So if you started off with the right thigh, you would inject about 1 inch in between injections for an entire week, and then you would move to the left thigh for an entire week. And then on the 3rd week, maybe you'd come up here to the abdomen on the left side, and then on the 4th week, maybe the right side of the abdomen. And so by the time you make it back to the right thigh, it's been 4 weeks since the last time you injected there. And this helps prevent buildup of fat deposits and scar tissue, and it improves insulin absorption rates. People will have favorite spots, and that's okay, but it's important to talk to them about the fact that their insulin is most effective and most evenly absorbed if they rotate sites. It's also important to note that certain sites like the back of the arm and even the buttocks are going to be hard for a person to inject on themselves. And so if they want to use those sites, they might need somebody else to inject for them. The injection angle should be 90 degrees unless the patient is cachectic or very, very thin and they have no subcutaneous fat, and then you could inject at 45 degrees. Patients with severe hyperglycemia who have type 1 diabetes may develop diabetic ketoacidosis, or DKA. When this occurs, their glucose level is typically greater than 250 milligrams per deciliter. They start with the polydipsia, the polyuria to the point where they have dry, cracked mucous membranes, and the polyphagia, although they oftentimes have abdominal pain, nausea, and vomiting. They start developing ketones, fruity breath, and ketones in their urine, and the urine actually smells very sweet. They may also be spilling glucose into their urine. They have Kussmaul's respirations, which is a rapid, deep kind of sighing respiration that occurs in order to blow off acids. And so that's a sign of metabolic acidosis with respiratory compensation. And you'll notice that they have a positive anion gap on their blood work. When this happens, sometimes they'll also become hyperkalemic. And the reason for that is one of the blood buffering compensations that we have is for potassium to kind of leak out of the cell and for hydrogen ions to be sequestered or kind of buffered into the cells. So our actual cells themselves can help with metabolic acidosis by kind of sequestering hydrogen ions. But in order to do that, the potassium leaks out. And so you can become hyperkalemic as a side effect of acidosis. Cardiac monitoring then again becomes very important because potassium can cause cardiac arrhythmias. And the treatment is to provide fluids, to balance the electrolytes, and to provide insulin. Remember that regular insulin is the only one that can go IV. And then really keep an eye on the potassium, because as you are giving insulin, insulin and glucose take potassium with it as it enters the cell. And so even the person who started out with hyperkalemia may rapidly become normal and then hypokalemic from an insulin drip. Patients with diabetes type 1 also are at high risk for hypoglycemia, and this is when the glucose is less than 65. Now, each person has their own threshold. Some people may normally have symptoms, below 70. Some people may be able to tolerate it down to 40. This can occur when you have more insulin than food, insulin and no food, or more exercise than food. From a nursing or provider perspective, one of the things that's super important to remember is that you should not give coverage unless the person is going to eat. And so giving insulin too early or giving insulin then to somebody who does not eat is far more dangerous than waiting to give coverage until they have started eating or after they have eaten. So, when you think about kind of a risk ratio, there's not really risk to giving the insulin a little bit later. There's a lot of risk to giving it early. They will go into shock with hypoglycemia. So your brain needs oxygen, glucose, and perfusion in order to function. If you don't have adequate perfusion, you're going to feel thirsty. If you don't have glucose, you're going to feel hungry. So they're going to get hungry, they're going to feel shaky, they're going to have pale, cool, clammy skin, and then they're going to look kind of like your stereotypical shock person: anxious, restless, hungry, confused, pale, cool, clammy skin from that sympathetic activation, so the epinephrine and the norepinephrine, tachycardia, tachypnea. And then as the blood glucose continues to drop down, they're going to have slurred speech. Typically, seizures occur when the blood glucose is roughly in the range of 20 or lower, and then coma and death can occur as well. It's important to remember that the brain is seizing from lack of glucose, and that is a really significant seizure and can cause permanent neurological damage, so you need to act quickly. Give sugar by the safest route possible. If they are awake, you can give them PO if they're able to protect their airway and swallow. You can give IM glucagon if you don't have IV access and they can't swallow, or you can give IV dextrose. And the dextrose of choice would be D10, and give a 250 milliliter bolus of D10, which is the same amount of glucose as a amp of D50, but you don't have the risk or the same risk as a D50 for cerebral edema. Type 2 diabetes is a completely different beast. This is insulin resistance. So with type 1 diabetes, I just don't make any insulin, but with type 2 diabetes, I have insulin, but I have chronic hyperglycemia from the inability to move the glucose into the cells. So why are they called the same thing? Well, just why do we have diabetes insipidus? Because they all have polyuria and polydipsia. And really, when we're thinking about diabetes, what we're thinking about is the running through of water. So then the hyperglycemia part of it becomes the mellitus, and the insipidus part of it becomes the, ADH issue. So it's the second tag on it, the mellitus type 1 or the mellitus type 2 or the insipidus, that actually kind of differentiates between these. And then we have like gestational diabetes and other things as well. So just keep in mind that just because these have similar name tags on them, they really are not the same disease. So diabetes type 2 is insulin resistance. So it's named diabetes because of the polyuria, but it's not the same problem. So we've got chronic hyperglycemia that leads to kind of an overload of the cell membrane, and it stops responding to every request for insulin to unlock the gate, and it requires more insulin and glucose to open the pathway and to enter the cell. So in the diabetes type 1, basically they've lost the key. They don't have any insulin to get in at all. But diabetes type 2 has like rusty locks, like they can't open the door even though they're standing there with the key and their bags packed and the passenger, and they're ready to go in. The lock is too rusty and they can't open the door. Diabetes type 1 is typically caused by an autoimmune disorder. Diabetes type 2, however, is caused by both non-modifiable and modifiable risk factors. Modifiable risk factors include a BMI greater than 26, but the risk really increases if the BMI is greater than 30. Physical inactivity, a low HDL, and an elevated triglyceride, and then the development of metabolic syndrome. And metabolic syndrome is kind of all of those things: abdominal obesity, hypertension, elevated fasting glucose, decreased HDL, increased triglycerides. Non-modifiable risk factors include a first-degree relative with diabetes, ethnicity, so that would be African American, Latino, Native American, and Asian American Pacific Islander. Women who had gestational diabetes and macrosomia, so a 9-pound baby. Patients who have hypertension, polycystic ovarian syndrome, and if you've had a hemoglobin A1C that was above 5.7 on previous testing, that puts you at a greater risk, as well as a history of cardiovascular disease. The onset of type 2 diabetes is slow, months to years, And when it does manifest itself, typically the person has the 3 Ps, so polydipsia, polyuria, polyphagia, as well as fatigue and poor wound healing. They've often developed heart and kidney disease, visual changes, and recurring yeast infections of like skin folds and the genitalia, any place that's kind of like, warm and damp and dark. Treatment is focused on modifying those modifiable risk factors, managing blood glucose, and minimizing long-term complications. The patient who has type 2 diabetes is at risk for developing HHS as part of their severe hyperglycemia. So where the patient with type 1 diabetes who doesn't make any insulin at all can develop DKA with a blood sugar greater than 250, the person who does make some insulin, so type 2 diabetes, starts having problems usually with a glucose of 600 or greater. That's really significant. So the body doesn't typically go into DKA with type 2 diabetes. Instead, they experience this profound hyperglycemia, sometimes over 1,000 milligrams per deciliter. The serum osmolality becomes 320 milliosmoles per kilogram or greater, so they become really super dehydrated. The serum pH is typically greater than 7.3, so they may have mild acidosis, but they're usually hanging out between that like 7.3 and 7.35. Bicarb is greater than 15, and they have possibly small ketonuria with absent to low ketonemia, so there's no ketones in the blood, and this is because they're really dehydrated, but it's not starvation ketosis. So this is different than diabetic ketoacidosis, where they're getting starvation ketosis that is putting them into a metabolic acidosis. This is just a small amount of dehydration driven ketones in the urine from the polyuria. And then they also oftentimes will have altered mental status as the glucose gets higher. The goals of therapy are to restore fluid and electrolyte imbalances. So the person should constantly be looking better hydrated, and their glucose should be coming down, their mental status should be improving. Chronic hyperglycemia impairs almost every organ in the body. We have impaired immunity, so we're at risk for pneumonia, urinary tract infections, skin infections, and the risk of sepsis is increased from any insult to the pulmonary system, the urinary system, or the skin. Vascular disease is more common, as well as diabetic ulcers. Diabetic retinopathy causes blindness. Diabetic nephropathy causes kidney failure, and peripheral neuropathy from the diabetes puts them at very high risk for injuries, as well as, again, skin problems and ulcerations. There's also an increased risk of heart disease and stroke. So when you have a patient who has type 1 diabetes that is well controlled, they still have these risks, but they're minimalized. When you have a patient who has type 1 diabetes who's poorly controlled, their risk factors become more closely aligned with somebody who has type 2 diabetes and chronic hyperglycemia. Thank you again for watching. I hope this is helpful.